I want to thank my fellow panelists for fabulous presentations. And I think, yes. And with apologies to the rest of the audience, we are going to engage in a dialogue with the committee. So I am sure that probably every single one of you has a comment or a question. So I don't know if we just want to go just pass the mic and so we're in.
Sure. Good morning, everyone. Is this on? Okay, great. Good morning, everyone. My name's Marcus Henderson. I am a registered nurse in Philadelphia. Ooh, there's no coffee in there. Don't worry, it's finished. A registered nurse in a child and adolescent inpatient psychiatric unit here in Philadelphia. So thank you to everyone for such a wonderful presentation. I learned so much. One of the things that pointed out to me is that nurses' work is hard work, but it's meaningful work. And resiliency and the well-being of nurses is very, very important, especially as we look at this study to increase nurses' ability to function in this space addressing social determinants. So I'd be interested to hear a little bit more about what your agencies or what you do to support well-being and resiliency, which is an area that we're very much looking into on this committee.
On. Okay. We've looked a lot at the work of Dr. Martin Seligman, University of Pennsylvania, on resilience, and that it is it is a skill that can be learned and enhanced, and there are tools to do that, and we have shared that information and those tools with our health centers.
Within our organization, I think one of the most unique things about the Nurse-Family Partnership model is that we talk a lot about emotional refueling, and it's part of how we encourage our families to prioritize self-care, because, you know, if you're not able to take care of yourself, you can't take care of your family. So we do a lot of modeling. So within our organization is something that we constantly talk about. We actually have a therapeutic space within our organization. We also have something called reflective supervision. So nurses meet with their supervisor weekly to really discuss you know, the impact of the trauma that they're experiencing and how they're managing that. So I think those are, like, you know, the reflective cycle and encouraging self-care and emotional refueling are some of the things that, you know, we do in our organization to make sure that nurses are able to continue to do this work. And one of the things that I think in nursing school is that that's also important to be able to model that. So whatever it is that, you know, faculty can do to ensure that students are taking care of themselves, then they can, you know, they're modeling that behavior so that they can take that into their own practices.
So this is tough in school nursing because we are an independent practice and often work in isolation. However, we on a national level encourage nurses to be members of our national organizations, the National Association of School Nurses. We also encourage nurses to be, oh, is someone clapping? Yay. We also encourage our school nurses to be part of the county organization and the state organization, but we are an independent practice. And while we are the chief wellness officers of our schools, like much in nursing, we don't always do a great job of self-care. So this is an area that we really do need to focus on. It's not one of our greatest strengths. We're very much focused on what's happening for our students and families and staff. So thank you for pointing that out.
I'm Greer Glazer. I'm Dean of University of Cincinnati. So I've got an education, not on. I'll just talk very loudly. So Greer Glazer, Dean of University of Cincinnati. So I've got a question related to education. You brought up the really excellent point. You're doing such great work. We know the Edge Runners have done really wonderful work, that we need to move our research-based programs to social enterprise, and how we move beyond all these great research programs to actually see something that's in action implemented. So what would be your curriculum recommendations for all of us in order to do that?
So we've spent some time here at Penn thinking about innovation, and we are fortunate that we are in an innovation ecosystem. We've had to take a look at our curriculum to ensure or to make sure that we are looking at design thinking. We have that as an elective, but we're also looking how to integrate that in other areas. I think one of the other important things, in addition to curriculum, and I know everybody wants to look at the curriculum and fix the curriculum, but that's not the only place to start. I'm looking at Dr. Cunningham, as CEO of the Hospital of the University of Pennsylvania. I think one of the other things as part of our innovation ecosystem is that we're working with Penn Medicine, who has a Center for Healthcare Innovation, and having our students and our faculty, as well as staff, participate in trying to solve what these wicked problems are. I think that the innovation that's going to happen is going to have to happen at the system level. It's going to have to happen in our health systems. It's going to have to happen in our schools. And we can't be looking at totally federal solutions or even state solutions to fund that. We have to look within our own systems to be able to do that. So again, I think a lot of what we do in nursing school in terms of the problem solving, in terms of the leadership, are important components. Skills like design thinking are important, and partnerships with whomever in the practice community to be able to look and to implement those things are what I'd recommend.
So in our Rutgers School of Nursing, Rutgers Camden School of Nursing School Nurse Certificate Program, we actually have our cohort, our second cohort, sitting in with us today. And actually, they are getting population health credit hours for attending this event. And so that was one of the real innovative things we did when we designed our program. We incorporated 45 hours of community-based experiences. All of our students are adult learners. They're all professional nurses. And so to really understand what happens in community, you need to be in the community. And so that was our biggest innovative change when we redesigned our program. Actually, based on the IOM 2010 report, we were able to get funding through NJNI as a grantee. And it has made a huge difference in what our school nursing students know to be part of school nursing. So they leave our program really understanding that being in the community is a huge part of being a successful school nurse. So,
Jack?
Yes, good morning. Jack Rowe, I'm a geriatrician at Columbia University in New York City. Yesterday, the committee had a chance to visit sites where there are interdisciplinary teams in Camden and here in Philadelphia that are very, very important approaches to effectively managing complex care, including the social determinants of health, including legal, housing issues, et cetera. But today's discussions point out that in several instances, whether it's the nurse-family partnership, there's no team, there's the nurse. The school nurse, there's no team, there's the nurse. And in many other settings, there's often just a nurse, particularly in elderly care. And that would seem to urge the question of whether we need a new kind of healthcare provider, a hybrid healthcare provider. A nurse social worker, a nurse whatever, somebody who has had educational experiences related to legal and housing and financial issues, as well as clinical care. Whether there might be room we're thinking 2020, 2030, okay? We're trying to think about innovations that might serve emerging needs. And I'm making this up as I go along. That may be obvious. But But I'm just sitting here comparing these examples to what we saw yesterday, and I'm wondering if anybody has a response to this or any experience that's relevant to this. Thank you.
I would assert that without having a hybrid, we already have nurses that are assuming that role. And when I when I mentioned the term boundary spanners, I believe that nurses are serving in that role. And in the community health center model, it is a team-based model, and the nurse is at the center of that team coordinating whether it's case management, whether it's social service, whether it's the medical care, whether it's needing medications. The list is
When there's a team. We saw one of those yesterday. I'm talking about when there's
not a team.
and then while the nurses may be serving that role, they're not getting paid for it.
Yes. Yes.
That's a good point. Oh, you're going to go.
Kind of healthcare provider with a different kind of certification and a different kind of training.
Right. I agree with that assertion. For instance, in our program, even though our nurses operate independently, when they come back to the site, they work as a team. But to your point, we have the Nursing Legal Partnership, and our nurses have participated in over 30 trainings related to the legal rights of our clients. So we essentially have now this advanced training in how to navigate legal needs before they become out even greater. I agree that there's room for advanced trainings or certifications for the extra work that nurses are doing.
I have to say, for school nursing, too, we really sit at the epicenter of care coordination for all of the things that you mentioned, and rightfully so. So what we need to do most is be that person to coordinate with what is already available within our communities, know our resources, make sure we're doing warm handoffs to families. I mean, that's a big part of our role. Now, of course, in terms of is it reasonable, though, when you have a ratio of one school nurse to 4,000 students across multiple buildings? We don't want to just put out fires. We want to be that effective person doing the work, not just the tasks. So you see, I completely understand what you say, and I think, and there's lots of school nurses in here today, I think we take on those roles because we need to do that. We must do that. And so high-level care coordination is very much one of the major principles of school nursing, especially in the 21st century.
So, Jack, I would say that is an area that's ripe for innovation. And I think, again, that's not going to be done at the huge national level, but maybe done in local levels and entities. I think the whole notion of community health workers actually grew out of a need of, again, extension of how to address social needs, how to communicate better, how to link better in the community. So I think that's one perhaps link that I think started off in a lot in community health centers that has grown in prominence. Interestingly, I just got an email yesterday from the dean of our vet school who wants to do a joint vet nursing program. He wants his vets to be trained as educated as nurses, because many times the only rural provider that they see are veterinarians. And if veterinarians can't if they can immunize and shoot up a horse, then they should be able to immunize a person for HPV. So again, I think those are things to look at and explore and to innovate.
Thank you.
Thank you. Good morning. My name's Vicki Tiazzi from New York Presbyterian Hospital. Thank you for your remarks here today. My area of interest is in clinical informatics. Erin, you talked about screening and assessment tools being used. And both Robin and Sherry talked about this idea of the isolation of the school nurse and the rural nurse, but collecting valuable data and information. I was wondering if you could comment on how we could either share and use this information better and use it to care for these patients differently, or perhaps give examples on where this is being done today.
It's my favorite topic. because it will save so much time, money, energy. It will stop parents from having to take a day off and they have no sick days, because at this moment, many school nurses have no choice but to have parents go get medical information that we should be receiving electronically. This is 2019. Moving into 2030, we need to have that shared health information exchange. And so this has been a real focus. One of the things that we've worked on at the Camden Coalition of Healthcare Providers, how can we directly communicate with our healthcare providers? We are on the healthcare team, and that has been a bit of a wall, a bit of a HIPAA misnomer about who exactly cares for their patients. It's the school nurse. And we should not find out that a student was in the emergency room because they come to school the next day with a bracelet. You know, these are the things that are still happening. So there is so much room for the expansion, especially in nursing informatics. It's a policy issue, truthfully.
Okay, Nick, anybody else?
Good morning. My name is Angie Mian from California. My background is in public health. And my question is for Alicia. You made a great point on the need for geriatric nurses. You said only 1% were certified. So how do we motivate nursing to get into the field of geriatrics? How do we do that?
One, we need to start in our nursing schools. All students and folks in programs believe that they're all going to work in the ICU and the ER, and they're going to be super nurses as depicted in models. But here we're saying in AARP, the growing number of people in the United States who will need care and complex care are 50 plus. And that we in AARP have been encouraging through our Center to Champion Nursing in America and the action coalitions across the country to begin to do those kinds of things that encourage students to see what it is that's needed in the future. And we need to, again, immerse our students, as I noted here, and our practicing nurses in understanding what's needed in this growing number of people in the United States. And I think that will begin to get people, we have to stop talking about older people as being elders and old. And as we say in AARP, we want to push to disrupt this whole issue and myths and challenges about aging.
Now, but you'll have the opportunity, the committee, to discuss with us here.